Vijay has said this is such a common topic that all of us need to have a very clear understanding. Remember here, doctors, I am not going to touch upon the clinical features or sort of clinical evaluation or symptomatology or treatment or anything. Plain evaluation of how a hepatitis B patient should be tackled in your practice. So this is based on the management of hepatitis B conference, which happened in 2011, and it is being updated time and again from the National Institute of Health. Okay, so this is a very internationally renowned presentation based on this particular talk. And I'm going to show you here what is called the University of Alabama. University of Alabama is a very renowned educational center. This is UAB, where there is a hepatitis web course. You can do these courses, and your friend Sharma doctor has done this some time back for some credits. And you can see there are several modules. Each module you have to finish and you get a credit at the end. And 11 modules are there on hepatitis alone. So that's fine. And those of you who are interested, you can go to University of Alabama and then do it. So we have the hepatitis. What are they? The A, B, C, D, E, and G. F is not there in human beings. So the ones which are marked red are the hematogenous hepatitis, and the brown ones are through the fecal-oral route, A and E. So we have some more disturbance is still there. I request all the participants to mute themselves, okay, so that the privilege for the host will be available to talk. So we are going to deal with hepatitis B today and not anything else. Okay, hepatitis B is a major cause of liver disease worldwide. All of you know, substantial cause of cirrhosis and HCC, hepatocellular carcinoma. That is the reason we need to be very careful to know this particular disease. And HBV vaccine caused a substantial decline in the HBV prevalence and incidence. And 7 types of treatments are approved as of now. We are not going to go into them now. Intermediate markers of the disease are available, and the ultimate aim is to decrease the chronic liver disease, cirrhosis, and hepatocellular carcinoma, and of course, death. Okay, you can see in this slide very worldwide distribution, and the ones in light green are the ones which are intermediate prevalence. We are in the intermediate zone. 2 to 7% is the hepatitis B virus prevalence in the world in the green, light green color. Dark green areas are more than 8%, and less than 2% are white in color. Why they are white in color? Because of a very potent immunization program with hepatitis B, which we do have, but we don't take. Even majority of our doctors are also not immunized even by now. If any one of you are still not immunized for hepatitis B, please get it done immediately. That is the answer. Okay, you see the Virion here on the left side. You see the two circles, one dotted circle, one ringed circle, and also dectahedron with DNA there in the center there. Okay, that is about the virus. Why this slide is required for us? You see these ones, these colored ones are what are called the surface antigen. Okay, surface antigen, HBS antigen. Okay, the next one, the red color dots are the HBC antigen. Remember, HBC antigen never comes into the circulation. So if a lab reports in the serum HBC antigen, that means it is false. It is not correct. HBC antigen cannot be detected in the peripheral blood. It can be done only a tissue. It will be there in the hepatic tissue. Okay, and then you have the star-shaped ones coming now and then. These stars are the hepatitis B E antigen. Okay, what are the 3 antigens we got? HBS antigen, HBC antigen, which is the core antigen. C stands for core, and E the envelope antigen, which is which comes and goes whenever the infection is there very much, and then the hepatitis B E antigen will be present. Okay, you can see on the right hand side some circles, semicircles, and all. This is a double-stranded DNA, the yellow, violet color, and the red color, that is semi-double-stranded, partially double-stranded. And then you have the open reading frames on the green, and also the brown and ORFX. What are these? So this is the one which codes for the C gene and ORFC. And this is for the surface antigen. This is the gene for the surface antigen. And there is another big gene called the ORFP, which is the polymerase gene, which is important for the multiplication of the virus. Why do I need to know that? Because there is what is called the pre-core mutation. A mutation can occur at this level, and that we are interested. That is why this diagram. Okay, as given here, we have got a HBS antigen, and then HBC antigen, and HBE antigen. And corresponding antibodies are anti-HBS antibody, anti-HBC antibody, anti-HBE antibody. Isn't it? Very easy to remember, but do not write something like, H and small b and capital S. What is that? H small b capital S is hemoglobin S. We are not talking about that. Supposing I write capital H small b and capital C, it is hemoglobin C. So beware whatever you are writing, use the specific uppercase letters in H and B, and the antigen you have to always write in the lowercase letter. So HBS antigen, HBC antigen, this doesn't appear in the peripheral blood. HBE antigen can appear in the peripheral blood when the infection is very severe, not otherwise. The corresponding antibodies are, of course, they will be in the serum. Anti-HBS antibody, anti-HBC antibody, and anti-HBE antibody. Again, emphasize the fact while writing a prescription for the test, please properly use the respective lettering and the casing. Now, come back to the test which we wanted to do. So there are certain serotypes and genotypes. As you know, the serotypes are ADR, ADW, AYR, AYW. These are the epitopes on the envelope presenting proteins, depending on the serotypes. We don't really bother much about that, but there are several genotypes. How many? 8 genotypes are there. In the HBV genome, there can be 8 different genotypes, starting from A to H. This is nothing to do with hepatitis A or B or C. All are hepatitis B only, but the genotype A to H, and it could be C, A, B, are very common in India. This is hepatitis B virus, C genotype, A genotype, B genotype. When I say genotype, this is not hepatitis A virus. A virus is called hepatitis HAV, and C virus is called HCV. That is, they are different. So among the genotypes, CAB are the 3 important genotypes which are present in India, and C is more virulent. Always we have difficult diseases in our country. Here also, that's the same case. So HBV C, HBV disease with C genotype is common and dangerous in India. So what are the 2 types of transmission? One is the mother to child transmission, which is called the vertical transmission. A positive mother, in the intrauterine life, she passes the hepatitis virus to the baby, or during the parturition, she contaminates the baby's blood and then produces a positivity in the fetus. So how do I prevent this? By immunizing all pregnant mothers and by screening all newborn babies and immunizing them. Okay, this is the way we do it. And then what is the horizontal transmission? Horizontal transmission, there is a hepatitis B person who is positive and hepatitis B positive, and he has a negative contact. This gentleman has picked up positive and he had a contact with his wife and he gave it to her as a donation, as a free Diwali gift, and she got hepatitis B, and that is the horizontal transmission. Okay, why I need to know? Because the prevention is different. Hepatitis B, always immunize the pregnant mothers and screen the newborns of the positive mothers. Okay, and then horizontal transmission is a very common mode of transmission, and the presentation is slightly different. We see here perinatal transmission is very efficient because a lot of mixing of the blood, and then do not show acute HBV illness at all. Directly they will go into the subclinical phase. Whereas in the horizontal transmission, just like any other acute illness, there will be acute viral illness. Whereas here, that is missing. So we miss the acute infection. Infection is more serious, leads to chronic hepatitis B virus and hepatocellular carcinoma, and complete recovery is rather unusual in the vertical transmission. Just the opposite in the horizontal transmission. Very common mode of transmission in our country is not homosexuals, not IV drug users, but it is the vertical transmission is a problem in our country because of poor maternal and child health care. Okay, now horizontal transmission occurs in the adults, and this is, I told you, from a positive person to a negative contact, it can occur. Less serious, less chronic hepatitis B, and less hepatocellular carcinoma. That is the basic difference between the two. Hereafter, it is all diagnosis only. We are not going to go anything further much. So how HBV is transmitted? All of you know there should be a blood-to-blood contact or blood and infectious fluid contact like semen or saliva. Okay, semen and saliva contain large quantities of this virus. Maybe due to sex with an infected partner, injecting drugs involving sharing of the needles, syringes, drug preparation equipment, and contact with blood or open source of an infected person, needle stick injuries in case of healthcare workers, or sharp instrument exposures, and sharing items such as razors, toothbrushes, and other things. And of course, birth to an infected mother is the vertical transmission. Now, how much blood is required? What is the efficiency of hepatitis B virus? If one has to get HIV virus transmission, they require 0.01 ml. 0.001 ml of blood is required. And the prevalence risk of transmission is that much. Okay, in HCV, one more zero is added. Okay, if somebody is HBs positive and HBe negative, that is they are not active, this much amount of blood is required, sufficient. And if they are HBe and ES positive, both very active disease, the efficiency of transmission is as much as 40%. Look here, 0.000000001. That is 6 zeros followed by 1. Such an amount of tiny contamination is just sufficient for HBV transmission, and the risk of transmission from an active patient is as high as 40% compared to risk of transmission of HIV or HCV, which require this much blood, and this is the efficiency of transmission. Here, the efficiency of transmission, rather the danger of transmission is so high with hepatitis B. All of us should be aware, very unnoticeable amount of blood contamination can result in hepatitis B. Okay, you require to know 3 important things as far as the virus is concerned. The common hepatitis B virus we have is called the wild virus. It's called the wild virus. Okay, there are mutated viruses. There is a pre-core mutation and a core promoter mutation. This pre-core mutation is 40% in Asians, and 60% of the mutation in us is core promoter mutation. Of course, we have wild type also. A person can have wild HBV, pre-core mutant, or core promoter mutant. Why this is important? This is important in the diagnosis and also in the treatment. That's what I'm going to show you now, not of course about the treatment. This is the crux of the total presentation. If you remember this slide, you have remembered everything. I'll just trace it through for you. So there is an x-axis. You have got the weeks after exposure, 0 weeks to 52 weeks, 100 weeks, we have traced. What happens at the end of 4 weeks, the hepatitis B surface antigen starts appearing, and it will peak by 12 weeks and then become negative by 24. HBs antigen will become positive, and naturally the body, in most of the patients, the HBs may be dropped. Simultaneously, what will happen? By about 6 weeks, the antibodies start appearing. The first antibody that is coming up is the yellow line, which is the IgM anti-HBC. IgM, we all know, is for acute, and IgG is for the remote infection. Even any disease, IgM is acute infection, IgG or total is for the chronic infection. Then the other antibody that develops is the chronic infection. Anti-HBC total, that is IgM plus IgG, that lasts longer. This is forever. Once it's infected, this will be there forever. Whereas this drops after about 32 weeks. Which one? The Ig. Now, at that time point, there will be antibodies for the HBs start appearing here and then go on and they continue for a long time. So now what happened? Now we have got the HBs antigen and we have got the acute antibody, IgM antibody. We have got the chronic phase antibody. We have got the surface antigen antibody. And here you see there is no HBs antigen, there is no HBs antibody, and that period is called the window period. Because neither the antigen, surface antigen is detectable, nor the antibody is detectable. That lasts around 8 weeks, and that is called the window period, which shows up, of course, the IgM antibodies are absent and these are absent, but the total antibody will be positive in such a person. Okay. Then how about HBe antigen? The HBe antigen occurs very early in the disease and the antibody starts appearing around 16 weeks and it will continue. So this slide is very important. As I told you, the first antigen to appear is the HBs antigen and 32 weeks onwards, HBs antibody will be there. The chronic antibody will be positive, that is the total anti-HBC will be positive forever. The acute antibody immunoglobulin M will be positive for a short period and comes down by around 32 weeks. So that is the time. And HBe antigen antibody, HBe antigen in the beginning and antibody for a longer time. So now, different tests we have. So we know the course of illness will be horizontal and vertical. Horizontal, this is the common mode of transmission. But in India, vertical transmission is the commonest mode. All over the world, horizontal transmission is more because mother immunization is very common in those countries. And intravenous drug users and then promiscuous sex are more common there. So vertical transmission is important for us and horizontal transmission is important for them. Okay, now the horizontal transmission fellow can go become immune tolerant. Get these words correctly. Then immune active, then inactive carrier. What is immune tolerant? Immune tolerant means the virus and the person have written a memorandum of agreement. What is the agreement? Oh virus, you do whatever you like. Multiply, don't bother, but don't invade my liver. Don't cause disease in me. And it will say, no, you fellow, you don't destroy me. You do your work and your liver, I will see it is not affected. And there is some sort of mutual understanding. Virus multiplication is there, but no injury to the liver. That's why it is called is having immunity and it is just tolerant. Then immune active. The immunity is there, but the immunity is taken over by the virus. Virus multiplication occurs. Active disease is there. Liver injury starts occurring. The inactive carrier is the fellow is having only the virus and liver injury at all, and there is no immune sort of active immune response going. Okay, now immune active can go into cirrhosis, inactive carrier can go into HCC or vice versa, and cirrhosis and HCC are interrelated. HCC is hepatocellular carcinoma. Okay, now HBs antigen. How do I go about testing? You all know you order for a HBs antigen assay. It could be a rapid diagnostic test or it could be a ELISA test. This is called A1, level 1 test. You do it. The result will be twofold. It is positive or negative, reactive or non-reactive. They say reactive or non-reactive. Non-reactive means you can be sure that this person is not having HBV infection and the advisory testing only after 6 months or 1 year and depending on the exposure. Now, somebody is reactive, then you have to confirm the disease. All of us do not do that. And today recommendation is if HBs antigen is positive, it doesn't mean he is firm positive. You have to do a second test to confirm the positivity. Compatible with HBV infection and then proceed to supplementary testing. What do I do? HBs antigen, if it is reactive, then you have to go for a second test. What is the second test? You can do a HBs antigen again with the rapid diagnostic test or do a ELISA. Okay, and then it will be reactive and non-reactive again. If it is reactive, of course, it's confirmed. If it is non-reactive, inconclusive, may do the screening after 6 months or 1 year, depending on the symptoms. So this is a common fundamental blunder we all do not do. If somebody is HBV antigen positive, don't rush to conclude that he is HBs antigen or HBV disease or infection. What you have to do a second test. How long? After after a week or so. What test? Preferably the same test or an ELISA. And if the second test is also positive, yes, we classify him as HBV infection, not disease. HBV infection. Infection is different from disease. Supposing the second test is negative, first test is positive, then it is an inconclusive result. Then we have to again follow him up after 6 months or so. Then what do you do? What do I do? The next one would be, I do what is called HBs neutralization test. I can do either a second test with HBs antigen or a neutralization test. Here what I do, I supply antibody to the HBS and see whether the HBS antigen in the sample is neutralized or not. If it is neutralized, of course he is having the disease. Not neutralized, not confirmed, equivocal result. There are two ways of doing the second test. Either I do a second test also HBS antigen with rapid diagnosis or ELISA, or do a neutralization test. This is not always available. So my preference would be to go in this direction and sort it out. Okay, somebody is HBV positive, two tests. But what do we call him? He is HBV infected. Now this is a crux of the summary table, which tells you the various types of scenarios that can occur in your result. Very carefully note the first line. Read the first line. HBS antigen is negative. Negative, I mean hereby both tests, not one negative. When I say negative, already true negative by two tests. HBS antigen negative. Total anti-HBC, total, the chronic antibody is negative. And anti-HBS antibody also is negative. That means what? He never had the antibody. He never has the evidence of surface antigen. He doesn't have any evidence of antibodies that he had a disease. Such a person, we classify him as susceptible and vaccinated. Understand? A susceptible person is one, surface antigen is negative, surface antibody also is negative, and then the chronic antibody is negative. That means his body has never seen a HBV virus. Such a person is called a susceptible, and he is the right candidate for vaccination. Okay. The second line you come. In the second line, HBS antigen negative. The same scenario there. Always negative means two tests there. But the chronic antibody is positive. And HBS antigen also, antibody also is positive. Means what? He had an infection. That is why this is why HBS antibody is there. And the chronic infection is evident here also. But this is dropped after 24 weeks. We said HBS antigen will become negative. That is called immune by natural infection. That means he had an infection and the HBS antigen dropped. The corresponding antibody is the S antibody and the total antibody, C antibody, are positive. Okay, come to the third line. Third line, HBS antigen negative, total anti-HBC also negative, but only and this is positive. Means what? He never had the virus in total, but had the immunization. That is why this is positive. So a person who is immunized and immune due to vaccination will have only anti-HBS antibody and will not have HBS antigen or the total chronic antibody. Okay. Now comes the scenario where you have a HBS antigen positive. This is commonly where the patient strikes you in your OP and then he comes and say, Madam, I have got a report. This is HBS antigen positive. Then what do? Do an acute antibody that is positive. That is IgM antibody is an acute phase antibody. And still the anti-HBS has not yet developed because he's just come. That is the first sign of acute infection. This is called acute HBV disease. Acute HBV disease is absent in the mother to child transmission. Acute HBV disease is a feature in the horizontal transmission. Now go to the next line. HBS antigen is positive and the chronic antibody IgG antibody is positive, but the anti-HBS antibody is still negative. That means the antigen is so dominant and the antibodies are not developed. This is called the chronic infection or old infection. This is the fellow we would like to further dissect and see whether he requires treatment, whether he is immune tolerant or immune active or chronic carrier. There are three routes for him. One is called the immune tolerant, IT we will call, and the IA immune active and chronic carrier CC. He will have three routes. Whereas the other persons we don't have to think about those things. And finally, there will be a person who will be HBS antigen negative, the chronic antibody, chronic phase antibody, IgG antibody is positive and HBS antigen is negative. What is the difference between the two? This is IgG positive, this is IgG positive, but here antigen of HBS antigen is positive, here this fellow is negative. That means what? Do you say he has infection? No evidence. Do you say old infection? There is no evidence. What are these antibodies? Are they really hepatitis B antibodies? That is why it could be a false positive, or it could be in the window period, or it could be a very remote infection. Okay, these are the different scenarios that you will see. Then what are the things you are going to look at? I have to ask for HBs antigen, that is 2 tests, and its corresponding antibody. This is the one. And I have to ask for total HBC antibody, and then also IgM antibody for the acute phase. These are the 4 things which we have investigated. For this man, we require something related to HBE, because HBE is the one which tells about the activity of the disease. So if there is no surface antibody, no surface antigen, and no chronic antibody, he is a susceptible person that is still vaccinated. The slide back so that all the lines would have gone. Now, the first line tells us a person who is HBs antigen negative, total antibody is also negative, and no surface antibody positive, means he is a susceptible person ready for vaccination. The second person, HBs antigen negative, total HBC antibody, that is the chronic antibody, is positive, and then the antibody, HBs antibody also is positive. That means he had the disease and dropped the antigen and still immune by natural infection. Here is negative here, and this is also negative, but only that anti-HBs is positive. That is because he is immunized and had anti-HBs antibody as a response to his injection. Just like you have your Covishield vaccine and the antibody for that you see. Similar to that here. Okay. These are all related to the vaccination, natural infection, and susceptibility. Now we come to the disease. Antigen is positive, must be having disease. Antibody is still negative, so he hasn't dropped the disease, and it is very acute. And the acute antibody is also positive, IgM. So it's an acute infection. It is not there in vertical transmission. It is there in horizontal transmission. Now, HBs antigen positive, and the chronic phase antibody is positive, and anti-HBs is negative. That means this is still not been overcome by the antibody, because antibody level is not sufficient enough to neutralize the HBs antigen. Such a fellow is called the chronic infection. He has got 3 roots: immune tolerant, immune active, and chronic carrier. That we will decipher in the next slide. And finally, a fellow is antigen negative, antibody negative, but the IgG antibody is somehow positive. Means what? It may not be HBV infection, maybe some other anamnestic reaction, or it may be a very fast, far remote infection, or he is in the window period. Window period you can easily overcome by doing the test after 6 weeks. You know about it. Distant infect, false positive also you repeat, and then another different type of method and exclude. And then still it is like that, it is a distant infection. Now, what are the tests I ordered? But from what we have discussed, the first test is called the HBs antigen screening test. So this is the first test. If it is negative, do a second test. If it is positive, go ahead with the rest of the panel. If it is negative, I do a second test, either do the same ELISA or rapid diagnosis, or do a antibody neutralizer. Usually antibody neutralizer, not available easily for all, just do a repeat the same HBs antigen. Confirm he is positive. If one test is positive, one is negative, that's called equivocal or divergent result, discordant results, and you need to follow it. Okay, anti-HBs antigen is done now. Then either vaccinated or infected, that is why he has the anti-HBs antibody is positive. If anti-HBs is positive, there are only 2 ways, either is vaccinated or naturally infected. Anti-HBC antibody, remote past infection. E antigen, active multiplication. Viral DNA, again quantitative evidence. Liver function, AST, ALT, acute liver injury. So this is the panel. Panel is whatever you have asked there. What we have asked? First HBs antigen screening, and then its respective antibody, and then the HBC total, and then H by C IG M. This we have asked. And with that, we have formulated where he goes into this table. And then we also have asked here HBE antigen, viral DNA, AST to classify our patients. I told you HBC antigen never appears in the blood. Only the antibody will be. All antibodies will appear. This also antibody will be there. Antigen will not appear. Either it will be HBS antigen or HBE antigen. S stands for surface, C stands for core, and E stands for the envelope. Envelope antigen is a sign of activity of the virus in the body. But is there a memorandum of understanding between the active virus and the liver? If yes, liver functions will be normal. If no, liver functions will be deranged and the virus taking an upper hand. If this is lower and the body immunity is more, it will be chronic carrier. So how do I know that? Sorry. So HBS antigen negative or positive. Two results are possible. HBE antigen also negative or positive. ALT normal more than twofold. Suppose normal is 22 and it should be at least more than 44. Okay, not 22 has become 28, no significance. It has to become at least 2 times the upper normal limit, UNL, upper normal limit. HBE antigen again, this is the antigen and you do an antibody may be positive, antibody may be negative, and you do viral DNA. Classify it as less than 10 to the power of 5 copies, more than 10 to the power of 5 copies. So these are the tests that we are, apart from the ones which we listed here. So these are the HBS antigen and its corresponding antibody, HBC total, HBC IgM. While writing the letters, be very specific. First 2 letters are capital. The small letter indicates what is the antigen or antibody you are looking for. Then you also look for the HBE antigen, viral DNA, and AST. So ALT, AST is useful only if it is more than 2 times the upper normal limit. Viral DNA is less than 10 to the power 5 or more than 10 to the power 5 copies is the this one. Everything is reactive or non-reactive will be the report. Now, look at this slide. What are the various antibodies? This is the DNA. So this is a patient who is HBE positive. As I told you, HBE positive means active disease. Of course, he has the viral DNA. And he has also got the anti-HBS antigen also is there. That is the second one, because viral multiplication is surface antigen also is there. Anti-HBE antigen, that is the green one, that is also there because of the active disease. And this fellow is HBE positive, so that will be there. And total antibody, HC antibody is also there. And IgM comes and goes after 28 weeks. This is the status of a person who is HBE antigen serology. What he will be positive for? He will be positive for HBE antigen and the corresponding total antibody of now the IgG type, and IgM will come and go. Viral DNA will be there and the HBS antigen will be persisting. Such a person is a chronic HBE positive patient. Now, how do I go about treating that person? How do I go about classifying that person? Does he deserve treatment? How do I know that? So HBE antigen positive, that's a sign of the disease, we know, active disease, and HBE antigen positive, then immediately what is the viral DNA? Is it less than 20,000 per international units per ml or more than 20,000 international units per ml? So that is you have to ask for a viral DNA. How did we come here? We first did a HBS antigen. And when the disease, 2 tests we did, and the person is positive, then we did a HBE antigen. And also did the other antibodies to see whether it is the chronic or the recovery or whatever it is. And then once HBE is done, it is positive or negative. If it is positive, means he's having active disease. The next question is, does he have active viral multiplication of a higher nature? How do I know that? Doing a HBV DNA less than 200, more than less than 20,000, more than 20,000. Then if the fellow is high, even if he is HBE positive, the DNA count is less than 20,000. It is in a very low level of multiplication. There is an MOU going on, and just see whether the MOU is valid or not by looking at the liver. Liver is not. Okay, Such a person is called immune tolerant. He has got the immunity, and that is why he is able to resist the liver. The virus is multiplying, immune tolerant. No treatment is required just for. Supposing he is more than 20,000, viral replication is occurring in a larger number. Then what is the liver doing? Is it damaged? No, no, liver is normal. Still, he is sort of having a compromise with this one. Such fellow is called a immune active disease. Active because the viral multiplication is there, but still immune because the virus has not taken over the liver. Now, 1 to 2 times upper normal limit, possibility of liver damage starting 2 to 5 upper normal, more than 5 upper normal, you can have different gradations. And these fellows are relatively better off compared to those who are more than 2 times or 5 times. And here the treatment comes, and next time when we have a class, we will decide what will be the antiviral agents, NUCs or tenofovir or entecavir. ETV is entecavir, tenofovir is TDF, and several other combinations, pegylated interferon. Several things are used, and treatment is not our today's class. Okay. Now I have to do some surveillance for hepatitis C. What are the two things I do? Do a hepatitis C surveillance by an ultrasonogram every 6 months in all HBE positive, and also do alpha fetoproteins of the liver. Two important surveys. One alpha protein, the other is ultrasonogram. Okay. So when you treat these people, some of them respond, some of them non-respond. How to go about them? When we are discussing about the treatment, we will go into that. Now, we are dealing with two types of people who are hepatitis E antigen positive and who are hepatitis E antigen negative. I always told you, hepatitis E antigen is an indicator of the activity of the disease. When it is activity of the disease, then I need to know whether it is really the liver is damaged or not. How do I know? I just do the hepatitis B DNA, and hepatitis B DNA less than 20, more than 20,000. Then ALT, AST normal, that means virus is multiplying all right, not too much, liver is not affected, then no treatment is required. Whereas if the virus is multiplying very heavily, then what is the liver like? Liver is normal, still he is immune active. This is immune tolerant, and this is immune active. Okay, now it is overwhelming, liver is becoming bad 1 to 2 times, 2 to 5 times, more than 5 times. Then this is a group who are relatively better off compared to this group, and these require treatment with entecavir or tenofovir or your interferons or any other antiviral agents. We will come and treat them the next lecture. When Girija permits me to have a next lecture, we can do that. Now, surveillance is I have to do HCC surveillance. What do? I do a AFP, and I also do a ultrasonography of the abdomen every 6 months, alpha fetoprotein and ultrasound. This is for hepatitis B positives. Now, the next one is hepatitis B negatives. Hepatitis B negatives are people who do not have the HBE antigen for two reasons. Either they are not very active or they are core or pre-core mutant. Okay, how do I know that? Do the copies. If the copies are less or more, the copies are less, look at the liver. Liver is normal, immune tolerant. Okay, here liver is slowly getting decompensated. This is called immune active disease. They deserve treatment. Depending upon, once it is more than 2 times upper normal limit, they deserve immediate treatment. Here, equivocal. Treatment decision can be postponed or can be done. And again, surveillance, AFP and ultrasonography for the hepatitis C surveillance. And now there are 3 types. One, immune tolerant, active, inactive carrier. Don't use the word healthy carrier because I think a healthy state. What is immune tolerant? Liver is normal. There is a multiplication and liver biopsy is normal. And this person, there is an MOU between them, is immune and tolerant. HBE positive, anti-HBE negative. Immune active, HBE positive, anti-HBE is negative, but liver is getting affected. The more copies are available, here less copies, here more copies. There is a chronic inflammation, need for treatment. Okay, this is in a case of wild infection. If it is core mutation or pre-core mutation, then the treatment is required. HBE may not be positive. It will be negative. Such a case, you go by the elevated ALT, more number of copies, and again, this requires treatment. And the last one are the group of people who are the chronic, inactive chronic carrier. Anti-HB is negative, and then the corresponding antibody is positive, and then normal ALT less than 5 copies, and there is a minimal fibrosis or no inflammation. In such a fellow, he is not a danger to himself, but he is a danger for transmission. Okay. Now, this is the summary slide, which tells you everything. I'm going to share a presentation, as I told you, and that will have 16 questions. Depending on this presentation, particularly this slide, you will be able to answer them. The first scenario is he has got hepatitis B virus into the body. Suddenly, like any other viral illness, there will be a immunoglobulin M positive. Immunoglobulin M is the acute antibody, right? And then the E virus also is, E antigen also is positive. That is because it's active disease, and viral copies are more, and ALT is there. 3 to 6 weeks, he will resolve and become normal. He may drop the infection, or he may become one of these. He may totally drop the infection. He may become inactive carrier. He may become immune tolerant or immune active. How do I know? Test the blood after 6 to 8 weeks. IgM becomes negative because by 12, 13 weeks, the IgM antibody is coming down. 6 weeks of infection, 6 weeks we waited, 12 weeks it became negative, but the antibody, the antigen E is still positive, suggests that it could be active, but it is not damaging the liver. But AST normal, but the viral copies are 10 more. That is multiplication is there. That is tolerant. In active, this is positive. These are also very high, and this is very much increased. Liver is affected. But of course, the antibody, acute antibody, would have come down by that. This is a wild virus. In wild virus, we have HBE positivity. If it is mutant virus, HBE may be negative, but the copies may be more, number of copies, and the liver effect may be there. Inactive carrier, antibodies have disappeared. No antigen E also, no active antigen. Very low multiplication going on. Liver is normal. Inactive carrier. He is not a danger to himself, but he is a danger for transmission. Okay. The injections are available for protection. All doctors kindly take Engerix-P 3 doses. This is the 0 is today, and 1 is 1 month, 6 months. And Recomvivax also can be given, and this is a slightly smaller dose and half dose. There is a combination of Twinrix. What is Twinrix? HAV immunization with B immunization. Together, that also 3 doses, 1, 2, 1, 0, 1, and 6 months. So this is to prompt all of us, all health workers must take the hepatitis, preferably Twinrix can be taken, or you can have separately HAV Rix. Now I would leave some time for questions because we have just touched around 1 hour. A few questions we will take, and we will stop here. Whom to treat, how to treat, when to treat.